My name is Andrew. My name is Andrew Chu, and I'm the representative from LU7. So this is my presentation for this month. Anyway, I hope you're having a great morning. So let's start first with the history of the patient, who is a 22-year-old female who came in with a 7-month history of biliary colic. So that's actually my interpretation of currently what's happening to the patient. So remember that the patient presented with epigastric pain radiating to the back. So more or less, that's like I consider that initially as a biliary colic because it was like the chronicity of the symptom was already 7 months. So that included an interim of weight loss and fever. So currently, my working impression at this time was cholelithiasis with cholecystitis because of the history of fever, at the same time viral hepatitis. So noted at this time that there was no history of melena and hematochezia. So that means at this time, it's kind of unlikely to have an upper GI bleeding and a lower GI bleeding. So 1 month prior to admission, we noted that the patient had multiple hepatic masses as shown on the CT scan and the ultrasound, and with a percutaneous aspirate as follows. So we could see here that the percutaneous aspirate result is kind of like unremarkable. So we noted that there's no organism, both the gram stain and the AFP smear. And at this stage, viral hepatitis is more or less unlikely because of the negative hepatitis panel as shown before. And currently, my working impression here are as follows. We could consider hepatic cystic masses, solid tumors, and abscess, and we could still consider cholelithiasis with cholecystitis. So let us work through one by one with the differentials of a cystic mass, solid tumors, and abscess. So let's start first with what are the differentials of a hepatic cystic mass. So one would be Caroli's disease. Now, I highlighted this in red because this is one of my differentials later. So Caroli's disease usually presents is less than 30 years old in more than 80% of patients. So what is Caroli's disease? I'm sure you're familiar with choledochal cysts. Now there are certain types of choledochal cysts. There are actually 5. So type 5 is actually Caroli's disease. So it is congenital non-obstructed gross dilatation of segmental intrahepatic bile ducts. So take note, intrahepatic, because there's also extrahepatic dilatation. And those are different types of choledochal cysts. Now, autosomal dominant polycystic kidney disease is also considered here. However, this kind of ruled out. This was considered because there's also associated manifestations of polycystic liver disease. However, this is unlikely as of this moment because there was no renal manifestations, such as later on we will note in the review of systems. Am I going too fast? Sorry. So for the solid tumors, we have benign and malignant. For benign, this is actually not quite considered because usually benign hepatic tumors are very asymptomatic and they usually present only with abdominal enlargement. However, in malignant, we would note the following. So I would discuss one by one. So for metastasis, this is unlikely as of this moment because there was no symptoms of bowel bladder changes. And of course, we have to consider number one, the age of the patient, which is still 22 years old. However, if the patient would be like more than 60 to 80 years old, then with a history of smoking and other vices, then we would consider pancreatic CA, gallbladder CA, and the rest. For gallbladder CA, the most common risk factor is still a gallbladder stone. However, that you should usually be in a chronic state. For colon CA and gastric CA, there was no noted of bowel bladder changes. For hemangiosarcoma, you will see this in the elderly. For hepatoblastoma, usually you can see that in less than 3 years old, almost universally less than 3 years old. For intrahepatic cholangiocarcinoma, the most common risk factor is still biliary parasitic infections and exposure to toxins. So let us discuss a little bit about hepatocellular carcinoma, as it is the most common primary malignant tumor of the liver. At the same time, this is most common in Asians. So we would note that the most common and first symptom of hepatocellular carcinoma is right hypochondrial and epigastric pain. So just take note now of the percentages. I got this from Slice and Gastro. So associated manifestations include weight loss, abdominal swelling, jaundice, hepatomegaly, ascites, and fever. However, this is very unlikely in the patient because number one, there are no known risk factors. So what are the risk factors for hepatocellular carcinoma? Hepatocellular carcinoma is usually present coexistent with cirrhosis. So what are the causes of cirrhosis? The most common is still chronic hepatitis B infection, chronic hepatitis C infection, and others. So which are more likely not present in the patient. Next, for abscess. So let's tackle first one by one, pyogenic, amoebic, and tuberculosis. For tuberculosis, this was considered because of the history of exposure. So for tuberculosis, we would consider hepatobiliary TB. So we would note, again, similar manifestations also with hepatocellular carcinoma. I'd just like to point out that in the peritoneal fluid, the sensitivity of acid fastings for MTB is less than 20 to 30%, and cultures have a sensitivity of only 50 to 70%. I got this from Henry's. So, going back, for the abscess, we have to differentiate between pyogenic and amoebic abscess. For pyogenic, it usually presents on there are usually multiple abscesses. However, in amoebic liver abscess, it usually presents single down. And pyogenic usually presents in either lobe of the liver, while amoebic abscess usually presents on the right lobe of the liver near the diaphragm. Thus, patients usually present with a pain radiating to the back. So, pyogenic usually presents subacutely with mild jaundice. Subacute meaning it occurs over the span of, let's say, weeks or months. However, in amoebic liver abscess, it usually occurs like acutely with approximately 2 weeks and with a moderate jaundice. For amoebic liver abscess, the aspirate is usually an anchovy paste or a chocolate sauce. Because of the trophozoites usually are very invasive, especially to the blood vessels, thus you would get this kind of hepatic aspirate. Now, let's discuss now. If this would be a pyogenic liver abscess, what is the cause of this pyogenic liver abscess? So we would now identify the source of infection in the biliary tract. Now, my primary consideration here is a choledocholitis still. So, you cannot have a cholangitis with just a stone. You need a stone plus a biliary stasis and infection of the biliary tract. Now, that's what can cause ascending cholangitis, which I will explain also later. So, choledocholitis. So, shown in here in the slide is the different kinds of choledocholitis. So, choledocholitis by definition is a stone in the common bile duct. So we have cholesterol stones or gallstones, and we have pigment stones. So highlighted in red are the primary considerations in this patient. I consider gallstones because of my primary impression of a biliary cholelithiasis, which just send it down into the common bile duct. And a brown pigment stone, which is usually caused by biliary parasitic infections, which includes nematodes like Ascariasis and trematodes, Clonarchis or Opistorchis. However, as I've read the protocol, there was no mention of any risk factors also, such as ingestion of raw vegetables for Ascaris and ingestion of freshwater fish for the trematodes. Now, looking at the course in the ward, 2 days prior to admission, we noted that the patient had presented with Charcot's triad. So that's fever, right upper quadrant tenderness, and jaundice, which includes anorexia, increased abdominal girth, bipedal edema, and an ultrasound finding of hepatomegaly. So basically, the review of systems rules out a lot of things. That includes neurologic, cardiac, pulmonary, musculoskeletal, and renal problems. So from this point of view, we can more or less rule out ADPKD, benign solid tumors, and malignant solid tumors. So my primary working impression at this time is pyogenic liver abscess secondary to ascending cholangitis, secondary to a choledocholitis, whether it may be cholesterol or a pigment stone. Other differential diagnoses are as follows. During admission, So during admission, so the patient now present with hypotension, tachycardia, tachypnea, dirty sclerosis, right upper quadrant mass with tenderness. So the current working impression now here is severe sepsis secondary to the pyogenic liver abscess and secondary to ascending cholangitis, secondary to the choledocholitis. Now, on day 1 to 4, we noted that the patient had decreased breath sounds on the right and basal rails from the left. We also noted that the patient had also pallor, same with Charcot's triad. And I would like to point out that there was hypertriglyceridemia, so there was increase in triglycerides, and there was also hypocalcemia, and a positive FOBT. So my primary consideration at this time was there was early complications of the choledocholitis, which includes blockage of the common bile duct, which led to an acute pancreatitis. However, hypocalcemia is only present in 10 to 25% of patients, and hypertriglyceridemia also more or less in 25% of patients. And the positive FOBT reflects the upper GI bleeding. Now, we would now think like, what is the upper GI bleeding caused by? So it may be hemorrhagic pancreatic necrosis, it may be erosive esophagitis. Now, these are like systemic complications of your acute pancreatitis. On days 5 to 9, we noted that the patient had tachypnea and nodular liver. Now, I would like to point out that the patient here now is having symptoms already of acute liver failure. So, acute liver failure was considered here because of coagulation problems such as elevated PT and PTT, and also the presence of hypoglycemia because there is increase in glucose synthesis, and hypoproteinemia in which there is increase in albumin synthesis. I would like to also point out that there was an increase in AST relative, there was a greater increase in AST relative to the ALT. Now, ALT is more specific to the liver. However, AST could be found in other tissues such as the pancreas. So that's why that may also cause the higher elevations of the AST. However, we know there's also such a thing as the AST-ALT ratio, in which if there's more than 3, it would point out to alcohol liver disease. However, this is unlikely in our case because there was no history of vices. At the same time, AST levels, if you're going to use that ratio, if it would be an alcoholic liver disease, AST would usually be less than 300. So finally, for days 10 to 12, we noted that the patient had already altered sensorium, GCS 13 to 14, and the patient was already on Levophed, with decreased bibasal breath sounds, globular abdominal tenderness, anasarca, jaundice, and poor pulses. The ABG also showed primary respiratory alkalosis with secondary metabolic acidosis with adequate oxygenation. Now, what am I thinking with regards to the ABG? The respiratory alkalosis here may be secondary to the tachypnea of the patient, secondary to the sepsis. So that's the reason why the patient is blowing off a lot of carbon dioxide. However, there is still a secondary metabolic acidosis here because of the sepsis that is going on and due to acute liver failure. So my final working impression is multi-organ dysfunction syndrome, secondary probably from the acute liver failure, probably from an acute respiratory distress syndrome because of the decreased bibasal breath sounds, and of course cardiac arrest because the patient died, and secondary to a pyogenic liver abscess, secondary to ascending cholangitis, secondary to a choledocholytitis. I could still not rule out a biliary parasitic infection or a cholesterol stone as of the moment. And still the same the other differential diagnosis. So these are the sources of my slides.
Thank you very much for the very comprehensive discussion. So now it's time for us to call